Good afternoon, I'm Beverly Oliver, Health and Wellbeing Programme Lead for the North East Public Health England Centre, and today we are joined by our guest speakers, Luke Robertshaw, Public Health Specialist Registrar, and Dr Claire Patel, General Practitioner, who will explain and share their experiences of how they have used the current COVID-19 pandemic as an opportunity to evaluate and redesign the NHS Health Check programme. We have a 1-hour session for today, and which will take the format of a webinar presentation, followed by question and answers at the end. And now over to Luke. Thank you.
Thanks very much, Bev. So yes, just to say hi and introduce myself. So my name's Luke Robertshaw, and I'm a public health registrar based in the North East region of England. And today we'll be presenting with my colleague Claire Patel, and I'll just let her say a quick hello before we get started as well.
Yes, hello, my name's Claire Patel and I'm a GP based in North Durham.
So Claire and I have worked pretty closely together on this project, kind of starting from the autumn last year. And I have to say from the beginning, it's been very much a learning process and quite a journey that we've been on. It wasn't like at the beginning, we knew exactly what we were going to do. We weren't following any kind of template or anything like that. So we kind of had to kind of look at our local situation, speak to people and kind of work it out as we went. So I think at the beginning, both of us had some familiarity with the health check programme, but I wouldn't say either of us consider ourselves experts in the NHS health checks. But certainly through the process of doing it, we were able to learn from various people who are involved in delivering them at different levels and from patients as well. And I think, you know, the fact that we came from different health backgrounds as well was quite useful in doing the review together, because we kind of came with slightly different lenses on the situation. So today we're going to give a bit of an overview of the general approach that we took. And hopefully this will be useful for any of you who might be considering looking at ways to improve your own health check programs. So of course, every context is different and there might be things that can be transferred. So if we could move on to the second slide, please, that would be great. So a bit of background about County Durham, where Claire and I have been based. So generally speaking, the population is in poorer health than the country in general. So if you were to look at things like life expectancy, we'd definitely be lower than average, and that's quite typical of most areas in the northeast of England. And this is particularly true for cardiovascular disease, where we see that we have much higher mortality rates and higher levels of risk behaviours linked to cardiovascular disease than other areas as well. And on this slide, those top 3 rows on the table are indicators for cardiovascular mortality. So the top one is premature mortality from cardiovascular disease. And then under that, we've got similar indicators, kind of breaking it down to heart disease and stroke. And if you look at the right-hand column, we've got a diagram that shows where Durham falls on a scale of all local authorities in the country. And the red vertical line in the middle is the national average, and Durham's that kind of dot, the red dot. And as you can see, Durham is worse than average for all of those cardiovascular outcome indicators. And then moving down to the bottom part of that table, it's more focused on the risk factors. So looking at smoking, overweight and obesity, physical inactivity and admissions for alcohol. And you can see that those as well, our area of County Durham comes worse than average. So as I'm sure you're all very aware that we know that these unhealthy behaviours are important drivers of CVD. And unless these are addressed at the source, it will continue to translate into a steady stream of morbidity and mortality from CVD in our populations. And of course, there's many others. I could add to it watching the England match last night. That definitely got my blood pressure up. But yeah, they're just some of the indicators we know and are kind of part of the picture of CVD. And NHS Health Checks continue to play an important part in wider strategies to prevent, identify and treat CVD. And in County Durham, the NHS Health Check programme is really part of a package of measures that are aimed at addressing CVD and other long-term conditions. So if we can move on to the next slide, please. This one's slide 3. So last autumn, Claire and I were invited to work together to review the local NHS Health Check service and make recommendations to improve it. And really the timing was important because it kind of fell quite nicely within the cycle for commissioning the service. The Health Check programme had been running pretty much in the same way for the past 3 years, and we were coming to a point where we were looking at recommissioning it again in the spring. So that basic commissioning cycle on the right of the slide, that's kind of a very crude diagram that gives a general process for commissioning. So you start off by assessing and reviewing the service, going on to develop any options for improvement or ways of changing the service to kind of adapt it, and then developing specifications for the service, and then procuring it, and then monitoring and evaluating it. So we were very much coming in at that number 1 on that diagram to kind of look at how the NHS health checks were currently being delivered. And the public health team had also, over some of the kind of contract monitoring over the past months, had raised some concerns about some issues with the local programme, particularly around kind of very few referrals to lifestyle behaviour programmes. And finally, the kind of pause in the NHS health checks due to COVID kind of gave a real opportunity to stop and take stock of the service, and then think, well, how can we get it started again, maybe with embedding in some changes and some improvements into it. So that's kind of how we kind of came to do the review. So if we could move on to slide 4, please. So when we set out to plan and conduct this review, we were keen to look at the service from a number of different viewpoints, and kind of hear the voice of service users and the voice of those who are kind of frontline delivering the service, as well as looking at various bits of data that we already had. So we kind of had these 3 different strands of information that kind of came into our review. So we fortunately have quite a rich data source that we get from general practice who deliver our health checks. So they're sending us regular data returns that includes information about the demographics of participants, the results of all of the tests that are done in the health checks, and information about referrals that people go on to take. So we had that kind of service activity data available regularly as routine data, but then we also went out and specifically sought patient feedback, and Claire's going to mention a little bit more about that in a minute. And then we also sought to draw in practitioner insights, so people really at the front line who kind of work with the patients and deliver those health checks. So we brought together these 3 strands of information, and then we did an assessment against a couple of different frameworks, really to identify strengths and weaknesses of the current delivery. So the first one was the NHS Health Checks quality standards, which I'm sure many of you are aware of, and that really looks at the process of health checks and looking at what good practice looks at each stage. And then we also did an assessment against another framework called Maxwell Quality Framework, which kind of looks a bit more at the population and whether services are meeting the needs of the population as a whole and addressing inequalities and some of those other kind of questions that we were interested in. So we basically we drew together all of that information and data, and then kind of did an assessment against those 2 frameworks. So I'll now hand over to Claire, who's going to talk us through a little bit more what we found. So over to you, Claire.
Thank you, Luke. Could we move on to slide 5, please? Thank you. So I'm going to take you through some of the review findings, and for us it was important to focus on the current strengths of the programme, as well as just identifying areas that could be improved. So a bit of background context, NHS Health Checks in County Durham are provided solely by the GP practices, and there's 9,000 health checks commissioned per year. Because there is a cap on the number of NHS health checks that are funded, and we're not reaching the whole eligible population, a decision was made by the provider, along with agreement from Public Health, to use a more targeted approach to the NHS health checks. And we use an estimated Q-risk score, which is generated from existing data in patients' GP records, to highlight those at higher risk, and they are prioritised then for invitation for an NHS health check. And certainly using this more targeted approach led to a service that was very proficient at identifying established cardiovascular disease, so high blood pressure, raised cholesterol, diabetes, and offering clinical treatment to those patients who would benefit from it. Can we move on to slide 6, please? So NHS health checks are delivered by more than 60 practices across 13 primary care networks in County Durham. And you can imagine that this gives a wide variation across the patch. And there was certainly a wide variation in the numbers of NHS health checks being completed within each individual practice. Some practices only achieving 3% uptake across the eligible population, with others achieving up to 25%. And there was a wide spread across those. There was also variation in the actual NHS health check itself. We come across some practices offering a single 15-minute appointment, whereas other practices were routinely offering 2 appointments. So an initial appointment for blood tests, data gathering, and then a follow-up appointment, and with a total duration of 45 minutes. So that's really quite a difference in the NHS health check being delivered in individual practices. From the patient feedback, one of the things that did concern us was that some patients were not aware that they had actually had an NHS health check. And this may have been when NHS health checks were delivered more opportunistically rather than through invitation. But we felt that it was important that patients were aware that they were undergoing an NHS health check and understanding the implications of that. And the other thing is that there was no standardised approach to the delivery of behavioural change advice. There was no standardised resources used, and it was very dependent on the amount of time that was available during the consultation, the training that the person delivering the NHS health check had. And also because this model of NHS health check is prioritising high-risk patients and prioritising case finding of established cardiovascular disease, then there was a de-emphasis on sort of lifestyle interventions and more sort of making sure that we were treating established disease rather than preventing or using risk reduction of future disease. Could we move on to slide 7, please? So this slide's got 4 different bar charts, and I'll not talk through them individually, but really do highlight the lack of referrals on to lifestyle and behavioural change programmes. From the service data activity, we have data from over 7,200 health checks. And this is the data that's entered by the healthcare professional completing the NHS health check, which is then sent back through to Public Health for analysis. And as you can see from these charts, the 2 on the right-hand side, the majority of smokers, 99% of smokers, and 100% of patients that were identified as having a HbA1c in the pre-diabetic range were offered a referral onto the National Diabetes Prevention Programme. However, when you look at physical activity, out of the 7,200 health checks which we have data for, nearly half of those were identified as being inactive or moderately inactive. Only 16% were offered a referral to a behavioural change programme, with only 3% taking that offer of a referral up. So in absolute numbers, out of nearly 3,500 patients identified as being active or moderately inactive, only 17 patients were referred. And we felt that that was a huge missed opportunity. Again, there was the bottom chart on the left, there were smaller numbers of patients identified with risky alcohol consumption, but no patients were referred on to alcohol services for support. So, you know, looking at that, even when offers of a referral were made, there was an actual low conversion rate into referrals that went ahead. Okay, can we move on to slide 8, please? As Luke said earlier on, it was very important for us when going through this review process to gain insight from a variety of different sources, and particularly the patients undergoing the NHS health checks. There hadn't been any previous patient feedback on the current delivery of NHS health checks, so we were keen to do that. And we invited all patients who'd had an NHS health check in the final 6 months of the programme delivery before it was suspended due to COVID to complete a Survey Monkey questionnaire. So that was from around about October 2019 through till March 2020. And this was sent out electronically from the GP provider. We had a fantastic response rate, and we had 529 responses, which we certainly hadn't expected to get that many, and felt that this was a real strength of the review process. As you can see from the chart on the left-hand side, around 50% of patients reported that they didn't receive any verbal lifestyle or behavioural change advice during their consultation. And also 35% of patients didn't receive any results following their NHS health check. And whether the NHS health check is performed following an invitation or whether it's done opportunistically, then it is still important for all patients to receive information regarding their results. Could we move on to slide 9, please? Okay, sorry. So just as some further patient feedback, we know that from the service activity data that I showed you with the 4 charts on slide 7, that nearly 100% of patients were recorded as being offered a referral to smoking cessation and the National Diabetes Prevention Programme, with lower numbers being offered for physical activity and alcohol. However, from the patient feedback survey, for which we had over 500 responses, only 11% of patients recalled being offered a referral for support with either diet and nutrition, physical activity, smoking, drugs and alcohol, or the diabetes prevention programme. And interestingly, 63% of those patients reported that they would be interested in meeting with a health advisor to discuss potential lifestyle and behavioural changes, either now or in the future. And again, we felt that this offered a huge potential for some meaningful intervention at this stage with the NHS health checks. Given the fact that high-risk patients were being prioritised for assessment in this NHS health check programme, we felt that we would have expected a higher rate of lifestyle advice and referrals being made. So it was quite interesting to see the difference between the data being recorded in the NHS health checks and the patient experience of that consultation as well. We move on to slide 10. So in November 2020, we held a stakeholder workshop to bring together key stakeholders and interested parties to develop options for future delivery of the NHS Health Check programme. And this included a wide range of representatives, including public health, general practice, the CCG, commissioning, and the community wellbeing services. And this was an opportunity for myself and Luke to present the findings of the review so far, including practitioner insights and the patient feedback. But we also use smaller groups to break out and discuss areas that we'd identified that could perhaps be improved to improve the NHS Health Check programme. Again, sort of not only just looking at any areas that we'd identified that needed to be improved or weaknesses, but also, you know, looking at the strengths and how to preserve the various strengths of the NHS Health Check programme. And as during COVID, this was a remote workshop using MS Teams at the time. I'm going to pass back to Luke to talk to you a little bit about the new programme. So I'll pass over to Luke again.
Okay, thanks very much, Claire. So yeah, I'll pick up the story again. So we had all this information from the review we did, and we've just shared, you know, some of the findings now. There were quite a lot more results that we found from the review, and then we'd also had the workshop that Claire's just described, which was actually extremely useful for generating ideas and, you know, getting different people from different backgrounds to kind of look at what was going on and give their perspectives. So we moved on from that really to develop options for improvement of the service. And we kind of came to three broad options. The first one was to kind of just carry on as we were. We've been doing it for 3 years, just kind of continue on. The second one was to basically look at the current process and just at each point try to optimize that. So that kind of assumes that we think the overall model is good, but we just need to tweak various bits. So that was the second one. And the third one was to actually make kind of changes to the approach and the model to try to resolve some of the kind of besetting problems of what was happening. So we considered those three options and we did a SWOT analysis, which I'm sure many of you are aware is a strengths, weaknesses, opportunity and threat. So it was quite, yeah, I mean, it was just using a very simple model to go through. And when we considered that, we came to recommend the third of those options. So if we can move on to the next slide, I'll just talk through a little bit what we've come to. So as Claire described earlier, the previous model was that the health check happened in one single appointment, and if there were any clinical follow-up concerns, then they go back into the GP for clinical follow-up. So that in the new model, patients will still come in to the GP for their initial health check appointment. And that's in the blue box there on the flow diagram. And the focus of that appointment will really be kind of data collection. So doing all of the measurements of, you know, height and weight, taking all of the blood sample, the blood pressure, cholesterol, HbA1c if appropriate, and doing all of the kind of questionnaires that we go through with people having health checks. And in that appointment, that would be the main focus. We're still expecting there to be very brief advice going on using MEC or similar kind of approach. But then after that appointment, we've then introduced this red box on the screen, which is a remote call from a wellbeing advisor to discuss their results and deliver behavior change interventions on the phone, and also offer referrals onto behavior change programs. So we've introduced that follow-up appointment for all. So after that, when that's happened, if anyone has any clinical need for follow-up in the GP, so they've got a Q risk greater than 10, then they would still be called back into the GP for a face-to-face follow-up appointment. But the main thing has been introducing that remote follow-up call. And this is going to be delivered by our wellbeing provider called Wellbeing for Life. And we've got 2 dedicated wellbeing practitioners who will basically call all the people having health checks in County Durham and go through a kind of standardized follow-up appointment with them. So the thing about this is it takes the pressure off that initial appointment to do all the behavior change advice and referral in one go, which was often difficult to achieve in the time. And also the quality was often quite poor, partly because of training and turnover of staff delivering them. And it was very difficult to kind of standardize that across practices. So I guess in this model, having the 2 people doing all of that means that we can easily standardize and ensure a high quality of behavior change advice being given. It kind of plays to the practitioner's strengths. So the healthcare assistant generally does the initial appointment, and the data collection part of that is probably within their kind of their core training. And then the wellbeing practitioner, their core training is giving behavior change advice and referral. And so it's easier to maintain that consistency across. So if we could move on to the next slide, slide 13. So returning to where we started off with that commissioning cycle. So we did number 1, we assessed the needs, we brought together all of that evidence, and then we went on to 2, we developed the options, and then we took this new model we developed and worked with our commissioning team to develop a specification for the new service. So whilst previously we had 1 specification for the GP practices, we now had 2 separate specifications, one for the GP to do the initial assessment, and then we had a separate specification with our wellbeing provider to deliver part 2. So that has all been done, and those services have been commissioned now, and they've started delivering the new model just a few weeks ago. But obviously, this is a new thing. We haven't delivered it like this before, and we've embedded into it an evaluation with one of our academic partners, Teesside University, who are going to be keeping up with the service providers and also discussing with people who've received health checks, their experiences, and repeating some of the work that we did in that initial review to kind of see if our new approach has solved those problems that we sought to address, but also hasn't sacrificed some of the real strengths of the previous model. So going back to what I said right at the beginning, this was very much a journey. I guess we're still learning. Be really interesting to see what comes back with Teesside's evaluation. And I think that's pretty much the end of what we wanted to present to you today. So if I could hand back to Bev, that would be great. Thank you.
Thanks, Luke, and thanks, Claire. Absolutely brilliant presentation, and in particular sharing those insights about how you've used the time when the NHS Health Check programme was suspended during the pandemic, about assessing the provision, engaging with partners, and in particular working with patients and service users, and how those recommendations have all come together to help shape a new commissioned service. What I would like to do is as the recording will now stop, we'll start and look at